All right, welcome back to the podcast. I am joined today with Tom Wooldridge. He is a PsyD. He is the chair of the Department of Psychology at Golden Gate University, as well as a psychoanalyst who is someone who has published on anorexia, eating disorders, male anorexia, um, and I'm excited to have him on the podcast to discuss eating disorders. And yeah, welcome to the podcast.
Thank you. I'm excited for our conversation.
Yeah, so tell me a little bit about how you approach eating disorders and how maybe it's different than most people in the field.
Sure. Yeah, I'd be happy to. So, my interest in eating disorders started when I was a doctoral student, and in one of my clinical placements, had a patient who was a young man with anorexia. And the way I was being trained to approach him was very much through a kind of symptom-focused, family-based intervention. And there was something about his journey, his plight, his suffering that really, I think, grabbed me emotionally. And so I decided to write a doctoral dissertation on male anorexia. And then, as the years went by and I started a clinical practice, I'm located in downtown Berkeley, so I was near UC Berkeley and also Berkeley High, and so had the opportunity over about a decade to work with a lot of young people that had eating disorders. And at that same time, I was on a path myself clinically of becoming more interested in psychoanalysis, developmental thinking. I trained as an analyst, and my effort has really been to bring the two together, to apply developmental and psychoanalytic thinking to eating disorders. Not certainly not as a sole treatment for eating disorders, but as a component of a larger treatment team.
Yeah, what was it about that case that really inspired you or got you curious or interested? What was it about that particular patient, do you think?
Sure. Yeah. So the way I think I was being, supervised to approach him at that time, it was not a strict, what would be called an FBT, family-based therapy model today, but it was very much a kind of family-based intervention drawn from Salvador Minuchin's structural family therapy. And so, it was not at all interested in the kind of meaning of the symptoms or what lay beneath the surface. It was very much more interested in what can you do with and to the family to address the symptom very directly, and the symptom being low body weight and refusal of food. So can we restructure the family system such that it supports this young man in regaining weight and restoring his ability to eat, which of course is a very kind of noble and worthwhile goal. I mean, I'm not knocking that in the least. I think that kind of intervention can be life-saving. And, I felt that there was something about the way I was positioning myself that overlooked the deeper story. It was clear that there was more going on, in the realms of attachment, in the realms of past trauma, in the realm of alexithymia and reflective functioning. I mean, these were the words I'd put to it now that I didn't, have so available then. But it was clear that there was more than just the symptom that needed attention.
Yeah, tell me about like we've talked about and I've heard you write about kind of like this empathy gap that may exist if you purely go after the symptoms. Like, what is the empathy that your approach gives to someone with eating disorder and the pain that's associated maybe underneath it?
Yeah, yeah, yeah. I mean, I think this is all in the realm of thinking about our countertransference, right? So when we're with somebody with an eating disorder, especially if it's a severe and life-threatening eating disorder, which it often is or has the potential to be, we're thrown into a realm, in the countertransference that is hard to tolerate. And that can take different shapes for different people and depending on the individual patient that you're working with. But there can be fear, there can be panic or even terror that this person will die. There can be, a kind of defense against that fear and terror in the form of very pressured action to do something to get them back up to the target weight really, really, really quick, which of course is important. But, can you do that in a reflective way, or is it in a pressured, way that's a response to an underlying feeling of panic? So, we're always thinking about what's the countertransferential state of the clinician. And if we're in a place of, fear, terror, panic, pressured intervention, it can be really difficult to kind of think into understanding and feeling into the inner life of the patient, which of course, I think we all agree is an important part of clinical work. Not that we want to get lost in it, but that it at least needs to be one lens that we're holding.
Yeah. Okay. So you kind of, when I ask you about the empathy for the patient, you first, I think, importantly talk about how we can, in our own fear, move more to action and less to sitting with them in the midst of their pain and understanding their pain. It's like it's almost too much. That's what you're saying? And then,
Yeah.
so what have you found is the pain, and then for this, maybe this individual and other patients as well. And how's alexithymia, or the lack of the ability to express an emotion, uh, how is that sort of intertwined in that pain?
Mm-hmm. 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 When we encounter a patient, if we have a psychoanalytic lens, I think that part of what we're holding in mind is that the place that they are today as they come to us is a result of a developmental process that came before. They've lived a life that's brought them to where they are now. And that life has had components in it that have shaped the journey to this point. And so, whenever I'm sitting with a patient, I'm thinking about what have they been through? What has shaped this expression, this symptomatic expression of pain? And that's what I think, psychoanalysts mean when they talk about the meaning of the symptom. What's the developmental history that has gotten this person here today? And if somebody's doing something like starving themselves, or, binging to the point of physical pain, or, binging and then vomiting, the underlying assumption is that that's an expression of some psychological pain that they haven't been able to work through, digest, make sense of, integrate into their personality into a meaningful way. So that's always the question I'm holding in mind. The symptom is a is a way to forestall a developmental process that could move them through whatever it is that they're contending with. And depending on the patient, what they're contending with could really, really, really vary. And I think that links to the idea of alexithymia, because alexithymia is this idea that there's no words for feelings. There's something about the person's ability to translate their emotional experience into words or images, symbols, representations, that is circumscribed or undeveloped. That's the alexithymia. So alexithymia is highly correlated with eating disorders, and it's one component of what prevents the person with an eating disorder from using words and making use of another person to kind of express their psychological pain so that something different could be done with it.
That's good. Yeah, I love how you're really searching to find the depths of what's going on inside of them. How do people respond to that, when you do that?
Well, I think it depends, right? So, as I kind of alluded to at the beginning, I very much think of a psychoanalytic approach as one component of a larger treatment team. So, people with eating disorders, they need multiple modes of intervention. There needs to be, depending on the individual situation, potentially a psychiatrist, an eating disorders informed physician, a nutritionist, maybe a family therapist or a family-based therapist. So there need to be multiple modes of intervention. And how quickly you can get to the underlying emotional pain in a constructive way with a given patient, I think it depends often, certainly on who they are, but also where they are in the recovery process. If somebody is at the depths of starvation, they're not really able to do, psychoanalytic work, because there certainly are developmental factors that can contribute to, say, alexithymia. But another thing that can contribute to alexithymia is physical starvation. So, if the person is severely undernourished, that is a place where I think, a psychoanalytic mindset can help with case conceptualization. It can help with managing the countertransference. It can help with thinking about what kinds of intervention might be helpful to this given person at this given moment. But there do need to be other things happening, trying to help them restore weight, at least to a point where they could make use of a psychotherapeutic process.
You talk about this study where they looked at the Shedler-Westen assessment protocol
Mm.
for a group of patients with anorexia nervosa and bulimia nervosa, and how the study really found three different groups of patients. And I think this is an important study to look at because I think often we think of these groups of patients as kind of in the descriptive lens of the DSM. But I think that this study added something. Can you talk about that?
Yeah. Thank you for that question, because I think that really does help unfold what is a kind of essential point here, which is that, nowadays with the DSM-5 or the ICD or whatever, our field is very oriented towards descriptive diagnosis, which really looks at surface level operationalizable symptoms. And, in that sense, a person with anorexia is similar to another person with anorexia. They're kind of homogeneous categories in some sense. Whereas I think the psychoanalytic sensibility is much more one of heterogeneity. There are two people with anorexia. I wouldn't make assumptions about the kind of underlying psychological structure of those two people. I wouldn't assume that they're the same. I would assume that there are probably multiple developmental pathways that can lead to that same DSM diagnosis. I guess that's the idea of equifinality in psychiatric jargon. So this particular study, it was a study with the Shedler-Westen assessment protocol, the SWAP, and it used that. That's an instrument that therapists complete, themselves to assess their patients, and it looked at patients with DSM diagnoses of anorexia and bulimia, and in the results of the SWAP, three different categories of patients emerged. So there was a high functioning perfectionistic group, there was a constricted overcontrolled group, and there was an emotionally dysregulated undercontrolled group. So, in a psychotherapeutic process, that has really important implications, because if you're just thinking in terms of DSM diagnosis, you've just grouped together, say, anorexic patients who are high functioning and self-critical with other anorexic patients who are highly disturbed, constricted, and avoidant. And those two different patients are going to need very different kinds of developmental relationships with the therapist, most likely, to move towards healing.
Okay, so let's go one by one to kind of highlight these three different groups. Because I think for someone who's listening to this, who's maybe, educated in a residency like I was, it seems like eating disorders are treated with DBT, very behavioral approaches. You get a nutritionist. We had a partial program, a day treatment program for eating disorders at the place I trained. And I think these three categories really open up something that is that can kind of add to our framework. So let's slow down a little bit here. So there's a high functioning perfectionistic group. Tell me a little bit about that group in particular, what you see, maybe what they look like when they come into your clinic.
Yeah, I mean, I think it's a good idea to slow down here, because it's important to look beneath the surface. This idea of a high functioning perfectionistic group, even just that phrase, it might in fact refer to very different kinds of people all grouped under that category. But, let's assume somebody comes in who's, quote unquote, high functioning. So, high school student or a college student, they're doing really well at school. Maybe it's a student at Cal, they're taking 5 or 6 classes, they're getting straight A's. As you're talking with them about that, you find maybe it's even more than that. Maybe they're staying up until 2 3 a.m, getting up at 8 or 9, sleeping very little, drinking a lot of coffee, pushing, grinding. So they're working really, really, really hard. So that says a lot to me. Just in that, it says that they definitely have some intact ego structure because they're able to kind of pull their life together in that way. That's a strength, that's a good thing. But something is leading them to kind of override whole other aspects of their person. Their need for sleep, their need for nourishment, their need for friendship, other interests that they might have. What is it that's leading them to push in that way? Is it an internalized, harsh parental voice, kind of superego? That's one possibility, right? I mean, did they grow up in a family where expectations were incredibly high, where there was a lot of shame around failure, weakness, vulnerability, lack? That's one developmental pathway that could structure a person in that way. Were they kind of humiliated in moments of weakness and failure by a parent, by someone else? We're thinking about the developmental history. What shaped the person to become like this? That's sort of the direction I would be taking it clinically as I'm sitting with this person. Not that you can always answer that question quickly. It often unfolds over months or even years.
Yeah, and so there's that type. The second one you said was a constricted, over-controlled group.
Yeah, yeah,
Tell me about that
yeah,
one.
yeah. Which seems, very, very related. I mean, you've got high functioning and perfectionistic versus constricted and over controlled, and maybe I kind of blended the two in the little case vignette I gave there. So, if I think of someone who's perfectionistic, they have a very well, one possibility is that they have a kind of ego ideal that's very difficult to attain. They have an image of who they should be that they're trying to live up to. Maybe they also have a very pronounced fear of failure. Something around this kind of idea of image of who I should be, what I should live up to. If I think of the idea of constricted and over controlled, it's more of a kind of clamping down on something, not wanting to kind of allow spontaneity or aliveness to be expressed. There's a kind of closing up of, say, emotional expression. And you can often feel that, right, in the countertransference. This is a patient that comes in and, different possibilities, but one is that they don't have a lot to say. They come in and they kind of look to you to lead the session. Or maybe they speak in a way that's very intellectualized and kind of removed from their feeling. Those are just different possibilities. I think both of these first two, the high functioning and the perfectionistic and the constricted and over controlled, you can really see a big contrast with the third group, which was the emotionally dysregulated and under controlled group, right? So that's a very different kind of patient that has very different kind of clinical implications for, what they need from you. This is the person that is having a lot of trouble regulating emotional expression. Maybe they, are not really going to classes. Maybe they're kind of binge drinking or binge eating. They're not functioning very well in their day-to-day lives. That's a very kind of different, a lot of interpersonal conflict. Maybe that's a very different kind of patient than one in the first two categories.
Yeah, is it kind of like is someone who's more obsessive compulsive versus someone who's more like borderline? Are those kind of, I don't know, are those categories kind of what we're talking about here?
I think, definitely the emotionally dysregulated, under controlled group, I would think of as more in the realm of borderline structure. The borderline, not necessarily, it could be, but not necessarily the DSM borderline personality disorder, but more of kind of what analytic thinkers would think of as a kind of borderline level of structure. And, it certainly could be, I mean, if you're thinking in terms of personality organization, the high functioning perfectionistic person could be, in the kind of obsessional category. There could also be a kind of narcissistic characterological component because, it could have to do with an ego ideal or self-image that they're trying to live up to.
Understanding this, how does that change um, kind of our conceptualization of this from the descriptive to this kind of descriptive way of understanding it? Or is this is beyond descriptive because now we're talking about like there's things that are leading to this
Yeah,
deeper things kind of.
yeah, deeper things. You could think of that as a uh, kind of personality structure. Maybe that's the depth component, or a person's kind of history that's led them to where they are. That's another component of depth. But it is, I think, much more than just the descriptive level. And why does that matter? I think it matters because, and again, I think this is the frame I bring to psychotherapy. It's not, I recognize it's not shared by all psychotherapists. But for me, the goal of psychotherapy is to create a relationship with a person. You call it a kind of developmental relationship that is going to facilitate their ongoing psychological development. I think of the symptom as something that has gotten in the way or forestalled their continued psychological development. And I'm now coming in trying to create a relationship with them that'll allow that development to continue. By knowing who they are in this depth dimension, you're much better positioned to form the kind of relationship that they need. Not that you can just, kind of construct it from nothing. But if I know, for example, that a person is, say they have a kind of narcissistic characterological structure, the way I speak with them and interact with them is going to be different than if they have an obsessional structure. If they're, more kind of narcissistically organized, I'll be thinking a lot about the potential of shaming them. Where does shame live in their psychology? What are they needing from me? Are they needing to be, seen in a certain way? How is that showing up in the countertransference? Whereas if somebody is more obsessional, I'm thinking about, well, how are they using their intellect? How are they using their mind to kind of organize our time together? What's happening to the feeling? Where is that being kind of hidden away? Very different implications for the way we would be together.
Okay, I like that. Yeah, so if someone's narcissistically psychodynamically oriented, um, there may be that shame that could spontaneously come out in the work that you have to be conscious of, like, okay, are they perceiving something I'm saying as shaming? And that's kind of something you're paying attention to. Is that right?
Certainly, yeah. I think, shame would be a kind of central affect in a person like that. For a person that's narcissistically organized, I guess there's different presentations, right? So there's somebody who's managed to kind of organize their self around, you could think of it as a kind of grandiose self-image. So they, present themselves in a certain way that is a kind of defense against shame. They present themselves as good and admirable and competent and, all that. At times, in a person with an eating disorder, this can be very much connected to body image, right? So part of what people with eating disorders are often concerned about is how does their body look? And the appearance of the body again can have very different meanings depending on the underlying psychology of the person. One meaning it can have is that I want to have a body that is to be admired, that is desirable, that is kind of within our culture thought of as a good body. That can be a kind of narcissistic concern. Another, kind of narcissistic presentation is a much more collapsed and vulnerable presentation. So such a person hasn't been able to pull off the grandiose self, in some way that hasn't been available to them. And so they're more in a kind of collapsed, vulnerable depression. Maybe this is a person that, is binge eating compulsively. Their only kind of avenue to find some soothing is in a binge. And then after the binge, they're left kind of awash in shame. It can show up like that. Those would be two different kind of pathways a narcissistic organization could go down.
Mm. And I like how you put, like, when you're working with someone who's more on the obsessive, they might use more intellectualization. They might try to organize away from using emotion or looking at their emotion. So you're going to look for emotion, right? That's what you said.
Yeah, and I can't say too much about this because it's not something I feel I know a lot about, but I think there is a kind of implicit recognition of this in, say, you mentioned DBT earlier being a kind of intervention that, you were familiar with for people with eating disorders. Well, we've now got, RO DBT, right? Radically open DBT, which is much more, it's a very different form of intervention that's much more organized to people like that. It's very much about um, promoting a kind of openness and kind of working against constriction instead of, like, say, DBT working to increase regulation. So I think it's recognized in other forms of intervention, this difference we're pointing to.
One thing I've pulled from your work is alexithymia seems to be a theme that I hadn't really thought about with eating disorders per se. How did you stumble upon this connection there, and like how has that helped you in treating this population?
Yeah. I think, for me, I stumbled upon it in two ways. I mean, it's certainly something that is spoken about in the literature on eating disorders. It's been recognized for a long, long time, at least back to the work of, Hildebrook in the 60s, 70s. But certainly it's noted in the empirical literature now over and over again, this correlation between eating disorders and alexithymia. Alexithymia is also associated with attachment insecurity. It's associated with histories of trauma, abuse, etc. So there's a lot in the kind of empirical literature there that's important. It's also an important idea in the history of psychoanalysis that we can talk about if you want to. But just to ground it clinically for a moment, I think alexithymia became an important idea for me because I'm trying to make sense of what I'm encountering with patients. And if anybody that's worked with eating disorders has had this experience, I think, of not every patient, but many patients, especially with certain eating disorders, say anorexia would be an example, who comes in, they sit down, maybe they've chosen to come to treatment, maybe they're being brought by their parents, but as the therapy gets rolling, there's often such a feeling of emptiness, of foreclosure, of, speaking for the patient, I don't know what to say. I don't have anything to say. I don't need anything from you. I don't want anything from you. There can be long silences. There can be such a feeling in the therapist of ineffectiveness, of not having the patient with you as a kind of full participant in the process. There can be a real sense that there's incredible pain here, but there's just no way to get it into words. There's no way to talk about it. There's no real problem, except maybe that, the patient wants to lose weight, or, they're thinking about calories or food. I mean, very kind of circumscribed, concrete places where you can get traction. And so, there's a feeling of lack, I guess, would be one way to put it in the countertransference. And alexithymia, I think, is one way of thinking about that.
That's really helpful. I think I'm curious about your work with male uh, patients with anorexia specifically. Are there unique differences from female clients? Are there unique, obsessions? Um, what have you found is the difference? What are the similarities?
Yeah, I mean, that's something I've been interested in for a while now. And I think, when I first became interested in anorexia in males in particular, um, there was very much a feeling of a kind of under recognition of the fact that men can get anorexia, and that was reflected in the data that was passed around. 10% of people with anorexia are male, and now I think we know that that's a significant underestimate. It's more like 20 or 25%, maybe more. There was very much a feeling that so many cases of male eating disorders are mythed, in a primary care physician's office, in a psychotherapist or psychiatrist's office, that is just not thought of in the differential diagnosis because anorexia is thought of as a female problem. So, there was a very strong feeling that I wanted to work against that. I wanted to increase recognition that this is a potential problem men can suffer from, so that it would be recognized. I think there was also a sense that men face or boys face an incredible stigma in seeking treatment in the first place because anorexia is thought of as a woman's problem. There can often be increased shame around seeking help for it, and then there may also be things about male, how would you put it, what it means to be a man or a boy in our culture that are at odds with seeking help in the first place, just more generally. So what I'm getting at is that there may be additional obstacles to getting treatment as a male. So those were some of my kind of initial concerns. And then I think there's also the fact that eating disorders in general in men may tend to present differently. So, for a woman, for example, with anorexia, there's a seeking of a kind of thin body. There's a kind of body ideal that's very much reflected in our culture of, a very thin, kind of insubstantial physicality. And that certainly can be the case for a boy or a man. There are definitely, men or boys with anorexia who seek out that kind of body. But there are also a lot of young men who are much more oriented towards a lean, hypertrophic, muscled physique. And this is what you'd see in like muscle dysmorphia. And so, how muscle dysmorphia and anorexia are related is a really complex question. But it may be that there's something about, the male gender that leads people down the muscle dysmorphia path, whereas if they were female, they might go down the anorexia path. I don't know that we fully know the answer to that.
Do you find like how does someone like that, like let's say they're in more into the big muscles type thing, which is I'm wondering how do these people even come to seek treatment? Like because you wouldn't necessarily identify them as, this person is too slender.
Yeah, well, I think there, again, are different presentations, but if I think about some of the young men I've seen, say they're 14, 15, 16, somewhere in that range, um, they've started to do a number of things that come to the attention of their parents, for example. So, they've become very rigid in their diet. They're only eating, lean protein and vegetables. They're not, going out with the family for ice cream anymore. They used to love, tacos, but, nowadays they just get the meat with the lettuce. Maybe they've started to use, creatine or maybe even steroids. They've gotten a hold of some kind of supplement or substance that's oriented towards muscle growth. My kid, he used to be so happy, carefree, but now he goes to the gym every morning and every night for 2 hours. So there's an increasing sense that they're becoming rigid and controlled and driven and, maybe depressed. And the parents, hopefully might, pick up on that. And then that might lead them to treatment.
Yeah, I think there's a thin line between good aspirations and like excessive aspirations. There was one guy on my rowing team in college who comes to my mind when you talk about this. He would only eat like tuna and lean chicken and vegetables, And I think it was he was too obsessive to the point of being undernourished at times for the amount of work that we were doing.
Yeah. It's a good point, right? Because I mean, again, as you said, sports and exercise, those things are great, but there are sports that because of the practices that they incorporate, say making weight or things like this, where you have to cut for the sport or sports that hold out certain kinds of body ideals is very desirable. That certainly are risk factors for eating disorders. And then, I think with young men, just to stay with that, um, often there's a kind of pre-morbid overweight. Maybe this kid, 12, 13, was a little pudgy or had some, belly fat or whatever. And maybe they got teased for that. That's often something you see that there's a kind of history of teasing. And so, they decided to try a ketogenic diet. Maybe dad had had a lot of success with a ketogenic diet. And so now they're going to try a ketogenic diet. And that, is the kind of entryway into starting to mess around with the body and with eating. So, there's a developmental history that got them to this place.
Yeah. And in one of your articles, you talk about the value of rough and tumble play, but you also talk about when it goes wrong. Is this specifically something you've seen in male anorexics, or is this something in general that you've seen?
Yeah. So the ideas about rough and tumble play, they were part of a very kind of nuanced and in-depth way I was trying to think about anorexia and maybe other eating disorders. So it's not so much about just rough and tumble play in itself, though there is research that rough and tumble play can potentially be very facilitative for children. But just to kind of lay out that idea. So beginning with Hilda Brooke, there's this idea that people with anorexia emerge from families that have certain dynamics in place, or can emerge from certain families that have certain dynamics in place. And I think this is a very contested idea because, we don't want to stigmatize families. We certainly don't want to hold up some idea of like an anorexigenic family, that doesn't look at many other factors at play. People can develop anorexia from many, many different pathways. And, it's really a kind of perfect storm, a biopsychosocial perfect storm. But, there is a kind of clinical observation that's been made again and again and again. And in my experience, does often hold up, though not always, that people with anorexia are struggling with the process of separation and individuation, often because of the culture we live in and the way families are structured, separation and individuation from mother. So they're struggling to establish a sense of self that is separate and independent from the family. Anorexia often shows up around, puberty, which is a kind of second separation individuation. A child around 3 or 4 really starts to establish a sense of independence, can go out and explore the world and then return for refueling. And then around puberty, there's another kind of movement away and establishing ties with peers and, establishing more of a life outside the family. And that's often when the anorexia shows up and really undermines their efforts at that separation and individuation, brings them back into a place of increased dependency on the family. So one of Hilda Brooke and others' observations was that, the father in these families often struggles to step in and help the child with that process of separation and individuation. And so my question was, well, why? What's happening there? And one thing I noticed clinically was that it seemed like these patients were having trouble using their own aggression, their kind of aggressive, assertive energy to move out into the world. Their aggression tended to be self-directed as a kind of self-punishment, self-criticism, self-evaluation, and less of a kind of oomph, energy that takes you out into the world. And so I started to think about, well, what do fathers do with their children that facilitates that kind of expression? And rough and tumble play emerged as a kind of metaphor. If you're looking at the paternal relationship, fathers interact with their children, let's just stay with the metaphor of rough and tumble play, in a way that encourages the child to express their own aggression, not too much, not too little. And the father is also modulating his own expression. You don't want to be too dominant, which kind of overwhelms the child's attempts at expression. You don't want to be too passive, which makes the child feel too powerful. You're modulating your own expression of your aggression to facilitate the child's expression of aggression.
Yeah, I think rough and tumble play is so good for kids. And there's some kids that I see, my kids' friends, I can just tell they have not been wrestled very much and they need to be.
Right.
And my son, if I would wrestle him, he would do it every night. I try to get him to do other things like basketball and go rowing and stuff like that too. But he just loves and it's like, okay, I want him to keep fighting, right? So I never want to get him into a place where his body goes limp and dissociates. But it's like for him, the ultimate pleasure is when he's on the edge of like he's about to lose, but then he pushes through. Like for him, that's like the ultimate pleasure, right? And then I let him win a little bit. Um, so I'm just thinking about that myself.
And
Like,
yeah, I think it's a lovely example, right? And I mean, for sure, there's, temperament or constitution at play, and some kids will be more kind of inclined in this direction than others. But I think, it's a reality that's important. It's also a metaphor. But just to read, something I wrote somewhere. I'm not a person that can just, kind of cite articles without notes, but um, empirical evidence suggests that paternal dominance in rough and tumble play moderates the relationship between rough and tumble play and physical aggression. So, in other words, the father's capacity to provide appropriate levels of opposition is a key component in whether rough and tumble play facilitates or undermines the child's capacity to regulate his aggression. So I think it's exactly what you're saying. It's like titrating the
yeah.
father titrating his aggression appropriately. And I mean, this has links when you look at, say, muscle dysmorphia. One of the things that you see, and again, muscle dysmorphia is a kind of newer diagnosis, and so the research is really just starting to kind of unfold. But one of the things that you do see, and I've written about as well, is that there is often a history of premorbid bullying, and that can be by a coach, it can be by a father. There's some experience that the young person has had of being made to feel small and weak, vulnerable. And you can then see
Mm,
how the development of the musculature would be like a defense against that. Nobody's going to mess with me again.
yeah. And it's funny because like I feel like some of that probably is pretty adaptive for that young person, to like gain some mastery over this sense of powerlessness. And I would say
Mm-hmm.
is that in my mind, at least that would be better, to some degree having, this kid in martial arts or strength training would be better than just allowing him to go on in that feeling of powerlessness. But I guess the ideal would be as well to have it not be driven out of a sense of inferiority or trauma, interpersonal trauma. And so I think that's where your work comes in of like, okay, now what do you do with that? How do you work with that kid or, adult?
Yeah, I think that's exactly right. I mean, the idea that you could have a child that is maybe shy or has been teased or bullied, and they're able to get into, say, martial arts, and that becomes a real source of self-esteem and confidence. That's great. All for that. I think, depending though on what came before, you know, does the martial arts or the strength training or whatever take on a kind of frantic driven quality, or is it more of a healthy adaptation? That would depend a lot on what came before. And then also, are the feelings from what came before able to show up in other ways, be talked about and worked through so that the martial arts becomes a healthy adaptation versus a kind of frantic driven defense.
Yeah, I read the biography of Mike Tyson, and it seems like to some degree, um, he had a lot of bullying early on, um, some antisocial behavior that he talks about, but his and and a combination of not having a strong father figure. So when he met this amazing coach in his adolescence, he became completely obsessed. And it was that level of obsession that opened up opportunities for him that led to his success. That's probably not the person you're seeing in your clinic, though, is it? You're seeing someone who gets stuck somewhere. And I think Mike Tyson, in his biography as well, autobiography, he talks about how he got stuck later in life, really, using cocaine, uh, lots of uh, sexual partners as a way of, regulating his affect,
Mhm.
hundreds, if not thousands. And then he eventually found this therapist who was that sort of maternal force and a wife who he's currently still married to, who was extremely warm and consistent. And he was kind of in this frantic, chaotic place until those two people came into his life. So I'm guessing that's we're kind of talking about that, but and that could be an interesting case study to look at. But
Mm-hmm.
um, it's like both the you could see how with different athletes, the energy that they may devote to it is obsessional in nature, but it makes them great. And I think about my own kids, that they're probably not going to have that obsessional nature for any sport. Um, you know,
Yeah, yeah, or at least, hopefully not to that degree. But yeah, I think that must be a part of his greatness. It's a really interesting, kind of vignette. I mean, I one thing that stood out to me is this idea of father hunger, right? Which has been written about both in analytic theory and in eating disorders literature. Starts out with a guy named James Herzog, and then Margot Main has brought it into the eating disorders thinking. But it's this kind of longing for a psychological father. It sounds like, Mike Tyson very much had that, drove him into that, first coach that was such a big part of his development.
yeah. I tell me more about this father hunger. I know this is something you've thought about. How does that show up? How does that get helped? Are you as the therapist kind of providing a good representation of that to someone over time? Um,
Mm-hmm, mm-hmm.
does the hunger lessen? Do you get internalized into the patient over time? A sense of you of, so the father hunger lessens. What's your sense on that?
Yeah, so father hunger, just to define the term, is a kind of longing for a psychological father who can provide certain functions that, a real father sort of ought to provide, at least in our culture, often does provide. Doesn't necessarily have to be a man that's providing those functions. Maybe it is, maybe it isn't. But, functions like a certain guidance, a certain showing how to do things, helping a child navigate the expression of aggression. For a young man, it can involve, other things as well, like how to, navigate the world of dating and sexuality and, kind of relating to, women outside the family and this kind of thing. It is a very kind of culturally bound idea. And so, may apply more or less to a given person. And I think, it's a question of the transference countertransference. Some patients, as a therapy proceeds, this father hunger is something that can very much show up in the transference. There may also be patients that it shows up in their life, like say Mike Tyson, but it's hard to bring it into the transference for whatever reason. So it's not something that you can force or script, but it may show up in the transference. You may sense it from a given patient. And then it becomes something that can be, talked about and thought about. And I certainly do think it's true that, a therapist, at least with some people, some of the time, um, can provide some, we have this phrase, corrective emotional experience, which is a complicated phrase with its own complicated history. But it is certainly true that a therapist can provide a kind of corrective emotional experience to some degree for people that have that kind of longing. Yeah.
Um, how does the father hunger come out specifically with eating disorders? And does it? Is it unique? Do you see it more with people with eating disorders?
Yeah, yeah. I think, it would depend on the particular diagnosis, but say with anorexia, um, clinically, I often see it has to do with this process of separation and individuation. There can be, especially as a person starts to get better, especially as they start to recover more and more, a kind of longing for somebody who can show them how to be apart from their family. How do you kind of separate and individuate, become distinct from yet connected to your family of origin, and move into the outside world? How do you do that? How do you set your own agenda? How do you exercise your own agency? Show me how to do that. There can be very much that feeling. But it can be very different. Let's say a different patient with muscle dysmorphia who was very abused and humiliated by their father. they're looking more for a father that can be attuned and kind while also being a father. Is that kind of experience possible in the world? That might be the most alive question for them in a given moment.
Okay. Um, Coming back to this idea of alexithymia, you cite in alexithymia appears to decrease significantly post-treatment with all eating disorders. Tell me about that.
Yeah, I think that's an empirical citation. So it's just something that you see, that as people get better, they become less alexithymic. And so then, the question we'd want to ask analytically is, what kind of developmental process between therapist and patient facilitated that? Now, part of it may be, weight restoration decreases alexithymia, but it's not just that. And there is an analytic literature on this beginning, I guess, in the 60s or 70s. There's a increasing recognition that there's certain classes of problems or disorders that are associated with alexithymia. So, addictions, drug dependence, PTSD, and, eating disorders would be another. Probably there are others. And analysts would think of this as a deficit in what they call symbolic function. So we all have this ability to take a kind of raw experience, which is body sensation, right? I mean, emotions, they start out as sensation in the body. So we've got this kind of somatic level of affective experience. In health, we have this capacity to represent that somatic level of experience in images and in words. We have this ability to symbolize the kind of raw data of emotional experience. That's symbolic function. People with eating disorders struggle with their ability to do that. They can be very in touch with their body, but it may be more like, I feel hungry, I feel cold, I feel tense, I feel anxious. That's getting more towards a feeling, but they can't generally at the beginning of treatment talk in depth or with complexity about their inner life, their affective inner life. Their experience is kind of collapsed more towards this concrete level. And so something needs to happen between therapist and patient to develop that symbolic function over time.
Yeah, good. And then you also talk about this word of abjection, Abjection, which abjection,
Right.
um, which is commonly described as loathing that these types of patients will experience towards their bodies. Um, Tell me about this.
Yeah, sure. That's a tough one. So abjection is an idea that is developed by an analyst named Julia Kristeva, and her writing is difficult, and so it's a complicated idea. But just to try to lay it out, briefly. So the abject is that which is taboo or horrific or monstrous or disgusting. It's the parts of oneself that have been kind of rejected and cast out. So I think what Kristeva is trying to do, for people that are true kind of Kristeva scholars, they may not kind of go with me here, but I think what Kristeva is trying to do is get at a certain layer of experience that for many of us is not so conscious. So, examples of the abject would be like vomit or a corpse, or, she uses the example of the skin that can form on the top of a glass of milk if you leave it out for too long. These are things that are disgusting. They're revolting. They threaten us with contagion. Words like purity and impurity come to mind. So this is a kind of layer of experience that I think is actually present for all of us. For sure, it's present for all of us, but it's not something that we think about that much. But for people with eating disorders, it may be more present. It may be more prominent. So if you talk to people, especially when they're in the depths of something like anorexia, they're very much often in touch with the affect of disgust. The fat on their thighs is disgusting. The fat on a steak is disgusting. Sugar is impure. It's not a clean food. There's very much a sense, I think I give an example in one of my papers that I found in the media, the news media, of a young woman who was in an inpatient facility and would, I think it was roll up towels and cover the gap at the bottom of her door because she didn't want to be kind of infected with flying calories. I mean, that's a much more kind of psychotic expression of this fear, but it's
Oh,
at this level.
flying calories, like a fly or a
Flying calories, like
like pieces of dust.
well, so I don't think it was as coherent as that. I mean, I don't know. It was in an article I found,
Okay.
but I think
Wow.
it was at the level of, I don't want to be infected by this thing that makes you fat,
Yeah.
i.e., disgusting.
That's
Or,
probably
think about a person who's bulimic, right? They purge, they eat all this food, they're awash in shame, their body feels disgusting, and then they vomit and they feel clean, they feel pure. These are the kinds of words people will often use. So they're evoking a kind of level of experience, and this is important because we want to be able to kind of empathize with what they're going through, not in a kind of simplistic way. We want to be able to immerse ourselves in the experience of what they're going through.
yeah, no, I'm glad you're giving us this way of looking at it because some of us, this is the farthest thing from our experience. We love ice cream. We love a good steak,
Right, right,
none of that inspires disgust. Um,
right, right,
yeah,
right.
so it's but you could see how the moral centers, disgust centers kind of intertwine, how they get revved up, um, focused on things that would be nourishing.
Yeah, yeah, I think that's right. I mean, we don't live for the most part in a culture that's oriented around purity and impurity anymore. But, there still are cultures like that in the world, and Western culture used to be more oriented in that way. And there's a whole history here that's fascinating. I can't really talk about it at length, but some of the kind of earliest documentation of anorexia is associated with religious practice. So you've got anorexic saints and nuns, hundreds of years ago. You've got histories and traditions of asceticism that have a lot to do with purity and starvation. There are, I think, important links there.
There's this quote that you put here. I'll read it. Like many, I spent my childhood feeling disgusting. However, any evidence of that time is scant. The series of photographs that document my childhood, there is an absence that occurs about the time that I was severely anorexic. The reason for the lack of previous documentation is simple. Why or how could such a sight be documented? Even now, my eyes turn in aversion from memories tinged with a mixture of shame, disgust, and guilt. At the same time, I do remember the splinters of pride that accompanied the disgust. Pride at the beautiful, prominent set of ribs, the pelvic bones that stood in stark relief, causing shadows to fall on a perfectly concave stomach. Looking back at my experience, I wonder at the forces of pride and shame doing battle in a body that knows itself to be disgusting. Yeah.
Yeah, that's a quote from a woman who wrote about her recovery from anorexia, and I think it really does get at the level that we're speaking about. Disgust, pride, shame. Certainly disgust is very much a kind of at this level of the abject.
Robin,
Hmm.
2004.
Right.
Uh, this was a quote that you gave me. So this abject, how do you help someone who has this? Like, how does someone work through this when they feel this revulsion towards their body, this disgust towards their body?
Yeah. 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 Well, I think there's, no simple answer to that. But in general, I think we've talked about this idea of alexithymia. So, you're helping somebody through your developmental relationship with them develop their capacity for symbolic function. So first of all, they're developing the ability to identify these as emotional experiences that they're having and to give voice to those emotional experiences in the therapy relationship. And then, as the treatment proceeds, hopefully you're also, helping them develop what's called mentalization or reflective function, right? I mean, I think in one of the articles, didn't get a chance to read it in depth, but in one of the articles you sent me, and I've seen this in other articles as well, right? Low reflective function has an association with eating disorders. If you don't have the alexithymia to some degree worked through, then the reflective function can't get much traction, because you need to be able to have mental states to reflect on in the first place. But as a person develops their reflective function, I think that applies to these experiences of abjection. Can you think about them? Can you reflect on them? If you can reflect on them, then you can take, hopefully, meaningful action in relation to them. Seek out experiences that promote a satisfaction with the body, that promote a feeling of enjoyable embodiment. I mean, this is very far into recovery that we're talking now, but I think that's the general trajectory that you hope to see unfold.
Yeah, so this was reflective function. By the time our episode will air, I will have an episode air with Steele on reflective function. And in one of the articles that we discuss, there was a group of inpatient psychiatric patients. So these are inpatients with eating disorders. And the average reflective function score was 2.8, which for people with borderline personality disorder in the same study, it was 2.7. So it's very, very similar to people with borderline personality disorder. And the reason why I think that's significant is this is low, and this is something that can be improved with psychotherapy. And specifically, um, so just to back up to define reflective function for those of you who have not heard that lecture yet, reflective function is defined as very similar to mentalization, but it's very specific. So mentalization is the ability to know your own states, other people's states, read accurately into your own experience, other people's experience. So to some degree, there's some overlap with alexithymia. What am I feeling? Emotion. Um, to another degree, it's overlapping with empathy. What is someone else feeling? And but specifically, reflective function is scored on the adult attachment interview. And so it is looking at your ability to look at your own mental states and other people's mental states, motivations, the complexity of what was going on from age 0 to 12. And I think why that's important is because you're looking at your nuanced understanding of your developmental relationships, what you could or could not know in yourself and other people. And it's a scale that's gradable from -1 to 9. And so a score of 3, which is these patients with eating disorders and people with borderline personality disorder, it's a low score, which shows room for improvement. Now, there was another study on transference focused therapy that showed that reflective function increased from 2.8 to 4.1, which is significant because you're going from questionable or low reflective function to almost average reflective function. So you're getting a huge jump just with that 1 unit increase. Um, and so I think understanding that is so potent to understand the importance of what Wooldridge is really capitalizing here is that, you know, the depth therapy experience with some psychoanalytic sensibilities of understanding countertransference, transference is pertinent to making this shift of increase in reflective function. And this is why I get excited about it. If you're listening to this and you're like, wait, psychoanalytic psychotherapy for eating disorders, like, how does that make sense? Read about reflective function, read about alexithymia. Uh, this does make sense, right? That's my way of understanding it. And of course, I would also agree with this idea that there needs to be a team approach. Like sometimes when someone is way under BMI, their their brain may not be ready for depth work. I, would you how when you see patients in outpatient setting, have you had cases where you're like, I think this person at this state with this degree of low body weight is not ready for the type of work that I would like to do with them? Like, how often does that happen?
Yeah, I think it happens all the time. I mean, people walk in, to the office in all sorts of different, places in their process. And so, there needs to be a very kind of thorough evaluation at the beginning, including a medical evaluation of what level of care is appropriate for them. Do they need a higher level of care, number one? And if outpatient care is appropriate, what forms of intervention need to happen in what order? Or what's the priority in a given moment. And so often people push back. They often come in and they want to do psychotherapy, even though they're severely underweight and they're not kind of wanting to gain weight yet. And that in itself is a very complicated process that needs a lot of reflective function applied to it. You really need to be kind of very thoughtful about how you go forward. So you know, um, in an ideal world, right, everybody would come in and they'd say, okay, I'm ready to, get my body weight up. And then I'm going to start, a psychotherapeutic process to work through the underlying components here. And then, I'll try to sustain this gain in body weight over time. But that's just not the way it works. Some people are in that place, but other people come in and they've been, in an inpatient treatment 2 or 3 times. They're not willing to do that again right now. And so
Yeah.
something has to happen to get them to a place where they are willing to do that again.
Yeah.
So a lot of thoughtfulness, care, consultation, is often really appropriate for a clinician to think through a given situation. It's complex.
And then I know any thoughts on this reflective function stuff that I brought in and kind of my interest in it or how it speaks to the overarching interests that you
Yeah,
have?
yeah. I'm completely with you. I mean, I'll be interested to hear that episode. I'm definitely waiting for it personally. I think, this idea of reflective function was a big component of my own kind of postdoctoral training at Children's Hospital in Oakland, where I worked with, children that were 0 to 3 and their families. And it was such an important component of the direction a child's development takes, the reflective function of the clinician and the mother and the father, before birth and in those initial years. So it was really, really driven home to me in that postdoc what a central factor this is in parents that facilitates or derails a child's development. I think, the link to eating disorders is a really important one. And I think psychoanalysis, psychoanalytic theory, it has all these complicated ideas, developmental theories, this idea of objection, the ideas about separation and individuation. Those theories are, important for a number of different reasons, but I think one reason they can be important is that they provide scaffolding that we can use to reflect on what's going on in a patient, right? They give us a kind of vocabulary for thinking with complexity about a person. That is, I think, part of their use. And so, I think a therapist having that reflective function in hand. I mean, I think you mentioned this when we had an earlier conversation, something Steele had found about that being a really important common factor in therapeutic effectiveness. That's totally believable to me.
This was actually that study was post Steele.
Mm.
And it's something that I stumbled upon that got me really excited about this because I've been studying common factors for years,
Uh-huh.
trying to understand it, trying to, think about how, like, what is the active ingredient in good psychotherapy? And yeah, in this specific study, which I've cited a lot at this point in this podcast, but I'll cite it again. Um, when they looked at what made the best therapists the best, 70.5% of it related to their reflective function score. The therapist's reflective function score, meaning when you ran the adult attachment interview on the therapist, how the therapist spoke about their childhood related to their outcomes with their clients, which
Mm.
which if you look at all of the different aspects of how they score reflective function, it makes sense. It didn't have as much to do with actually their attachment style, the therapist's attachment style. It had much more to do with
Right.
their reflective function. Um, because, and I think about this as well in a when we think about countertransference, like when you have a countertransference response to a patient, if it's unconsciously registered and then reacted towards, that's a low reflective function stance towards that client. And I think that learning from you about, okay, these are the common things that occur in the countertransference, this actually increases our reflectiveness about what might be going on with us in this specific client. It can actually increase our curiosity about what's going on in ourself. And then that increases the reflectiveness, that decreases the reactiveness with clients, that increases our compassion and our empathy. Um, so when someone experiences something that maybe uh, that that you otherwise would react towards, and instead you have compassion, I think that allows the treatment to be powerful and effective for the client.
Mhm.
That may be the ideal perfection that I strive towards, which I need to um, have some compassion towards myself when it's not perfect. But
I think that's exactly right. Yeah, I agree with everything that you said, and adding in the recognition that of course we'll always fall short because there is, however you want to think about it, there is the unconscious, or there is dissociation and enactment. There's processes between therapist and patient that always foreclose our reflective function to some degree, but we're always working to open it up again.
yeah, and I would say this is where if you're a clinician and you're with a patient and you're in an enactment, which is like something maybe even from the patient's past is getting relived in the present moment with you and the patient. Or you can also be in an enactment where you are pulling the patient into a sort of type of relationship that's very common to yourself. I think good supervision, where you have a supervisor who can help you reflect with curiosity into what might be going on, um, especially in a way that decreases shame, because the shame will not allow you to explore it maybe in a reflective way. I think that can be important. Realizing that um, a lot of the greats of psychotherapy had very, uh, imperfect lives.
Mm,
Um, and so, you know, yeah, to not think that we are above it ever, right?
right.
Okay, so kind of as we kind of start to wrap up our own sort of work here together, are there any other categories that you wanted to speak to that we have not hit? Big categories on eating disorders, on working with eating disorders.
Yeah, I mean, I would echo that. I think, we're scratching the surface. We're focusing on something very particular, which is what can a psychoanalytic sensibility and theory contribute to eating disorders. That certainly has overlaps with empirical research and other forms of intervention. I think we've, alluded to this treatment team idea a number of times, which I think is um, again, so important, because I don't at all want to come across as saying I'm advocating for taking somebody who's in the depths of anorexia and putting them just in, an analytic treatment. Many different things need to happen for people in that place. And I think that, the sensibility we've tried to kind of unfold today can be a really important piece of that work.
Yeah, I would say, I mean, my sense is that if you had a client that came in who needed a higher level of care, you know, could it be that your connection with them was somehow maintained during that higher level of care? I don't know. Do you have any thoughts on that? Like when you send someone off to like a higher level of care, do you continue to correspond with them, talk with them, or how do you normally navigate that scenario?
Sometimes, yeah, or correspond with their families. It can take different shapes. I think, and this would be a whole other topic, and so I'll just speak to it very briefly. But how they're sent off to a higher level of care or a different form of care is really important. right? Because if you are a person who is, say, anorexic and you're going into FBT or inpatient treatment where there's going to be a strong interpersonal press towards renourishment, that in itself can be a very emotionally overwhelming experience. Your whole defensive structure is oriented around not eating. And now you're going to be pushed, sometimes pushed very, very hard to eat. And that, in itself can be, a traumatic experience, really, even as it may save your life. And so the way in which that transition, that handoff happens, requires a lot of thought and care because it's a pivotal moment in a person's life.
Any last tips for providers on how to be patient with the process of helping someone with the difficulty in alexithymia?
Yeah. I mean, I guess I just point to consultation as key, right? Because when you're with a person and the space in which to reflect and feel is very collapsed, a third relationship with a consultant or a supervisor can really help to open it up inside the therapist so that they can remain alive in a relationship that feels constricted or deadened. Consultation has certainly been key for me. Many different kinds of consultation, over the years, if you're working with people that have this degree of, difficulty.
Excellent. And any advice you would give to any patients who might be listening to this, who might be like, yeah, maybe that's what I'm missing. Maybe I need to find someone to help me in this regard. What would you say would be a good way of finding a good provider, finding someone with expertise?
It's a tough one, because you're speaking to, the patient, which is, you know, who's the particular person that needs the advice and the guidance, and advice and guidance needs to be so tailored to the individual. But just in general, I think, you want somebody that has training with eating disorders that can balance the pragmatic aspects of recovery and with whom you feel listened to and understood, not just kind of instrumentalized and treated. And I think that balance is really, what we're going for. Can they hold the practical and can they hold the emotional depth of what's gotten you to where you are?
Wonderful. Tom Wooldridge, thank you so much for coming on. Appreciate it. Um, if people are interested in learning more, uh, I will have links to your books, website in my show notes and in my the article that we will work on that will go with this episode and try to cite some of the sources of things. And yeah, any final closing thoughts?
No, it's been a pleasure. Thanks for the conversation.
All right. We'll leave it there for today. Thank you guys for listening and have a great day.